Hello, everybody. We are going to dive into now specific lung diseases. And the rest of this unit will be focused on restrictive lung conditions. So, our case is a patient who is a 55-year-old grain farmer with a history of pulmonary fibrosis. He has a BMI of 25. He presented to the emergency department 2 days ago in acute distress with severe shortness of breath, dizziness, and confusion. CT scan and cardiac enzymes came back negative for stroke and MI. So we quickly ruled out stroke and MI. Now let's see what's going on with this patient. First, I just want to encourage you, if you don't already, to have a kind of a snapshot of what BMIs suggest about a patient. In physical activity, we talked about the major limitation of simply basing someone's kind of overall body composition or health profile on a kind of breakdown of their height and weight. But there is a lot of normative data that helps to inform decision making on mortality related to BMI. So we take it with a grain of salt, but it does help kind of put patients into a spectrum, and so we kind of know what to expect when we're walking into the room. The far end of this, right, if we have extremely high BMIs, you might need extra help if you're going to be getting patients up. You might need bariatric grade equipment. And if it's on the low end of the spectrum, you're coming in thinking about, their nutritional their abilities, how well they're going to even be able to tolerate therapy from a very different end of the perspective. So BMI of 25 puts him kind of right in the middle range. He's not overly thin. He's not overweight. But if you don't kind of have those in your mind, practice associating BMIs with body shape to help you get a quick snapshot and inform some decision making that you'll do before you enter the patient's room. All right. In this class, so I don't have my whiteboard because we're in the digital world. Thank you, COVID. In class, I would give myself the one whiteboard challenge to see if I could give you guys the complete pathophys review on one whiteboard. So I will attempt to do the same thing with my digital whiteboard. All right. Welcome to my one whiteboard challenge. All right, so we have pulmonary fibrosis as our condition. Does anything come to mind? Tell me some seed took root. Is there a word that you associate when you hear pulmonary fibrosis? Please, oh please, tell me some of you thought of the word stiff. Pulmonary fibrosis is a stiff lung. This is a restrictive lung disease. After diagnosis, it has about a 2 to 3 year survival rate, so it is a bad diagnosis to get as a progressive lung disease, chronic, progressive, and irreversible. So if we draw a picture representing pulmonary fibrosis, I'm going to draw one single alveoli, and the mechanism of injury is pulmonary fibrosis is a disease of abnormal wound healing. So the cause of the disease is relatively unknown, but frequently associated with pulmonary fibrosis is some repeated injury to the lung. That's my repeated injury right there. By that, what do we mean? Repeated injury can be smoking. Smoking can cause pulmonary fibrosis. GERD is an example of a disease that's been associated because the acid reflux ends up that the patients aspirate acid, and the repeated exposure of your lung to even small, tiny amounts of acid creates repeated injury. There's a lot of occupational exposure. This used to be called miner's lung because it was so common in workers working in the mines. Repeated viral infections could be on this list. Something is repeatedly causing an injury in the lung. And a person who gets pulmonary fibrosis has the combination of bad luck in that they have a repeated injury and they have some component of a genetic predisposition to respond with abnormal wound healing. Because not enough smokers get pulmonary fibrosis. Not everybody who works in the mines gets pulmonary fibrosis. So, with the repeated exposure and the underlying genetic physiology to respond kind of inappropriately causes the pulmonary fibrosis. So the body is going to try to heal, and I'm just going to add in a blood vessel going by our one alveoli. Because in response to this injury, what we're going to see is proliferation and accumulation of fibroblasts and myofibroblasts. Kind of like we call way too many of them to the scene. Proliferation and accumulation of fibroblasts and myofibroblasts. So maybe we'll make these guys look kind of like this, little spiky dudes that show up on the scene. So here they come in. Fibroblasts and myofibroblasts arrive on the scene to try to help heal the wound. So fibroblasts normally come in right after the acute inflammation. And these guys come in and help lay down collagen to help heal once you've cleaned the area with all the acute inflammation to clear out the debris and kill off the bacteria. But in this case, in response to the injury, the body raises up fibroblasts and myofibroblasts. I just realized this is a misspell here. Let me just write that correctly. Myofibroblasts. The body raises up fibroblasts and myofibroblasts to the scene without ever having the acute inflammation first. These cells show up, and what do? They lay collagen. They spew extracellular matrix. So they start laying down collagen, extracellular matrix, thinking we have to heal. So this orange is all of our extracellular matrix being laid down. So the fibroblasts and myofibroblasts cause scarring and destruction. As they are laid down in response to this exposure of some irritant, let's put it that way. So what areas can be affected by this? Well, I tried to draw my lines kind of all the way across, because the scarring and the destruction affects the alveoli. The alveolar wall becomes thickened and fibrotic and scarred. The interstitium, as well as the capillaries, can get scarred down and can actually, in some cases, completely block blood flow to this area. One really, really big thing to think about here. This is basically the story. I even have space on my whiteboard left for some additional information. See, pathophys was so simple. You guys just didn't even realize it. All right, so this is basically the disease. What is missing from this story? I've already mentioned it once. There is no acute inflammation. This is very unusual. In our bodies, when we have an invader, when we have something damaging to our physiology, our body responds almost uniformly with acute inflammation. A lot of the diseases we talked about in pathophys, the symptoms were simply because of the dang acute inflammation, all the fluid that came with it. Pulmonary fibrosis has no inflammation, and the big thing in lung and this world that we're in this class is there's no fluid. And fluid in the lung is a whole other ball game. Pulmonary fibrosis is a dry condition. They're not coughing anything up. There's no sputum. There's no fluid because there's no acute inflammation. So what are the effects? Let's see. We'll put them down here. Lung effects to this pathological change in the alveoli, the interstitium, and the capillaries. Well, if the lung tissue gets wrapped in scar tissue and extracellular matrix, you would expect a decreased inspiratory capacity. You're not going to be able to get as much air in. Let's take that one step further, because we just got done talking about our pulmonary assessment. What does that look like on the outside? A person who's been walking around every day with a stiff lung that's hard to get air into, with less inspiratory capacity and more work to try to get the air that they have getting in. I would expect to see hypertrophy of accessory muscles, commonly associated with pulmonary fibrosis. There would be decreased expiratory volume. Why are we exhaling less out? Because we got less in the first place. So there's no problem in the mechanism of exhalation in pulmonary fibrosis. The only reason you have less expiratory volume is because you didn't get as much in the first place. The other really big effect is a decrease in oxygen diffusion. So the oxygen molecules that find their way into this alveoli, and it's open right at the top, there's nothing stopping the air from getting in, have this mess of scar tissue to try to navigate through to get into the blood. And that's going to affect diffusion. That's based on Fick's equation, that the rate of diffusion is proportional to the surface area for gas exchange, the delta P driving the diffusion, and inversely proportional to the thickness of the barrier. As the thickness of the barrier increases, you decrease the rate of diffusion. So what is this going to look like? They are going to have a difficult time with their PaO2, getting enough oxygen into the blood. Because of the reduced inspiratory capacity and the lack of ability to get oxygen into the blood, these patients typically take on a tachypnic breathing pattern. They start breathing fast but shallow. And the increased rate of breathing isn't fast enough to fix the oxygen problem. So you still expect to see decreases in their arterial oxygen levels. They just can't breathe their way past the diffusion barrier. But the rapid breath also is going to end up blowing off too much CO2. So actually they typically present with low oxygen and low carbon dioxide because they're breathing so fast, they're exhaling more CO2 than their body is producing through normal cellular metabolism. Finally, we could add on here the results of their pulmonary function tests. FEV1 is the volume of air you can expire in the first second. And if you make that in relation to their forced vital capacity, in pulmonary fibrosis and in restrictive lung dysfunction, they typically have reduced FEV1 and reduced FVC because they have less inspiratory capacity, which means they're going to have reduced FVC. And if there's less in, then there's less out, which means they have reduced FEV1. So those values are both reduced, but since they're often reported as a ratio, if both the numerator and the denominator are lowered proportionally, you actually expect to see normal ratio of FEV1 to FVC. Of the air that gets in, they don't have a problem getting that air out. But the problem is they don't get enough air in in the first place. That's it. One whiteboard, the entire pathophys lecture on pulmonary fibrosis. If you need more, please go back to your pathophys notes and review that section. So the slide that's in the PowerPoint represents kind of the textbook version of that same story, if you prefer that over my chicken scratch, where you can see the wall thickness of the alveoli increases, creating the diffusion barrier and ultimately contributing to the reduced inspiratory capacity. All right, let's do a chart review on our 54-year-old patient who has been admitted in acute distress with severe shortness of breath, dizziness, and confusion. Best thing we can do is a thorough medical chart review. Let's look at the drugs that he is on. He has a past medical history of pulmonary fibrosis. So he is on an antifibrotic that is trying to slow the progress of that abnormal wound healing of pulmonary fibrosis. And he's on a corticosteroid. I won't go too far down the farm road here. There's definitely research to say that corticosteroids shouldn't be used, but there's studies of this particular steroid when combined with the antifibrotic that decreases the rate of acute exacerbations of pulmonary fibrosis. So if it seems sort of weird to have a steroid on board when acute inflammation is not one of the main mechanisms, it has to do with probably some synchrony between these meds, but studies that have showed a benefit when they're both on board. But typically cortisol is on board for things that are inflammatory in nature. All right, so here are this patient's arterial blood gases. So PO2, 78, extremely low. This is definitely, they're going to be doing something to address this, likely probably driving part of the reason this patient was admitted with severe shortness of breath. Let's look at the acid-base balance. So if we create our balance of our pH and we put carbon dioxide on the acidic side and bicarb on the basic side, and we fill in our patient, 7.52 is his acids, or his acid-base status, I should say. His CO2 is low, so if 3 represents normal, this is low, just 1. Bicarb is 19, also low. So of the two of these, they're both abnormal. Which one would cause the scale to move to this direction? The only reason it's going to get tipped is if it was heavier on this side or if it was lighter on this side. Which one matches? CO2. So this looks like we are in a respiratory alkalosis. And because bicarb is outside of its normal range, that tells me that this body is trying to fix the problem, but since pH is still outside of its normal range, it hasn't been effective. So we have a partially compensated respiratory alkalosis. Let's look at his CBC. We see hemoglobin and hematocrit are elevated. This is kind of an expected abnormal finding for somebody who is in chronic hypoxia. If you have chronically lower oxygen levels, that is going to stimulate the release of erythropoietin, and it's going to stimulate your body to make more red blood cells. Because the body will try to fix the problem of low oxygen in the only way it knows how, and that's to make more carriers of oxygen. White blood cells are in the normal range. It seems unlikely this patient is dealing with an infection from that lab value alone. Platelets are within normal limits, so I don't have any great concerns about this patient having any kind of bleeding risk, and the metabolic panel is within normal limits. The top of the next page of your notes gives you the result of this patient's pulmonary function tests. FEV1, 2.8 or 60% of predicted. FVC, 3 liters, 64% of predicted. Let's jump into the pulmonary function tests and do a review, and then we'll come back to what this means for this patient. So pulmonary function tests are used to evaluate the mechanical function of the lungs. And what's important to know is that the patient performs these tests, and then the results of these tests are always compared back to some predicted value. That was what I was going to draw your attention to here, this 60% and 64% of predicted. The reason we do that is because our lung sizes are all very different based on our different body sizes. So your sex, your height, your age all play into what is kind of expected. And there's a ton of normative data that's been collected. And so pulmonary function tests are always given as a percent of predicted, because a straight volume measurement is not as helpful because we're such different shaped human beings across the spectrum. So in general, pulmonary function tests can measure volume, they can measure flow, and they can measure flow rates by that I mean, and they can measure diffusion capacity. Let's first talk about spirometry, which is a measure of volume of air and airflow. So in spirometry, that's where we're talking about these FVC and FEV1 tests. So typically we do a max inhalation followed by a max exhalation, and the spirometer measures the volume of air and time. You can do these tests in two ways. If you did it the way I described, where you do a max exhalation, if you tell the person to push out as hard and as fast as they can, that is called a forced vital capacity, FVC. And most often that's what's reported. You can do this exact same test, max inhalation, followed by a maxed exhalation, where the person just allows the exhalation to happen and they don't push it out as hard as they can, hard and as fast as they can. Or maybe you could call it a relaxed expiration. In that case, that's called a slow vital capacity instead of a forced vital capacity, or SVC. In a healthy person, their FVC should be equal to their SVC, or slow vital capacity. Those two should be the same. It's just a difference of time and flow rate. But in obstructive diseases where it's hard to get air out, you will typically see slow vital capacities which have larger volumes than forced vital capacities, because the obstructive disorders typically slow the rate of exhalation. So if given all the time in the world and they're not pushing hard, they actually get more volume out. So this is kind of a classic finding in obstructive. That's probably the only time you really see that SVC used, is to kind of separate out some information in the obstructive family. Okay, so then the volume that comes out in the first second, as we mentioned, is the FEV1, or forced expiratory volume in 1 second. Your FEV1 should be about 75% of your vital capacity. So FEV1 should be about 75% of your vital capacity, or above 70. And if it's less than 70, that is diagnostic for an obstructive disorder. And then as you can see in your notes, when you get below 25, that is a severe obstruction. So it's not abnormal to see patients with emphysema to have an FEV1 around 40%. That is, kind of a typical finding in an obstructive lung disorder. The information from these studies can be graphically represented in a flow volume loop, seen here, where you have volume of air on the x-axis and flow rate on the y. So if you trace this up, this would be the start of your inhalation, right? So this volume here represents your residual volume. And then you inhale, which creates a negative flow rate because this is your inhalation phase. As you fill the volume up during inhalation. So total lung capacity, somewhere between 5 and 6 liters, represents a full maximal inhalation. Then you tell the person to exhale, and you can see you have the highest flow rates initially because when you exhale with force, when you use muscular effort, the rate at which the flow is coming out is fastest at the beginning of your exhalation, because at maximal volumes you have the greatest amount of elastic recoil, plus you have the muscular effort of the muscles of exhalation being kicked in. So exhalation, you get both elastic recoil and muscle effort, which gives you a distinctive shape to this curve because you have higher flow rates at higher lung volumes because a greater contribution of elastic recoil when the lung is more stretched. So quick reminder about our lung volumes. You can see kind of a total lung capacity on the left of the screen. And it's important to remember that our tidal volume is typically only around 500 milliliters. So a pretty small amount of our total lung capacity just fuels our resting breath, which means we have a really large inspiratory volume when we need to get more air. That's referred to as your inspiratory reserve volume, or the additional volume of air you could inhale above and beyond your tidal volume. And your expiratory reserve volume is the additional air you could exhale at the end of a normal resting breath. So your breath naturally ends during a resting exhalation, which is passive, when the elastic recoil of your lung wanting to completely collapse, that inward force of the lung is equal and opposite to the chest wall, right? Wanting to stay open. When those two forces are equal, your exhalation ends. But you could activate your muscles and push more air out if you wanted to. That's your expiratory reserve volume, which when utilized gives you a greater total amount of air exchange because you can allow more air in on the next breath. Then obviously we never fully empty our lungs because we need a certain amount of residual volume to hold our airways open. If we completely collapsed our lung on each breath, it would take such a considerable amount of effort to snap open those alveoli. We need that kind of surface tension maintained to a certain degree with a little bit of volume so we can easily get our air in and out. So we always have some air left in our lungs for residual volume. Capacities are just descriptors where you put several of these volumes together to describe different kind of areas of the lung we use. So our inspiratory capacity is your tidal volume with your inspiratory reserve volume. Those to come together for your inspiratory capacity. Your functional residual capacity is the amount of air in your lungs at the end of a tidal volume breath. So it is residual volume plus that expiratory reserve volume. Vital capacity is the maximum amount of air you can move in and out of your lungs. So vital capacity is all of your volumes minus residual volume. And then obviously total lung capacity is the total volume or space that you have in your lungs. So we can collect information through these pulmonary function tests on the volumes that our patients have to use. And these have different lung pathologies characteristically alter these lung volumes. So pulmonary function tests can be used to diagnose lung dysfunction as well as track changes over time, especially because a lot of these lung diseases are progressive. So you can see that the pulmonary function tests can give us vital capacity. We can see the total volume of air we can move in and out. We can get estimates of total lung capacity. But this functional residual capacity is a tricky thing to measure, and it's very affected by disease. So it's an important measurement. But because within functional residual capacity is residual volume, which is the volume of air that we never leave, we have to do some kind of trickiness, pulmonary function trickiness, to measure the functional residual capacity. So the technique that we do is the helium dilution technique. And the method here is that it's a closed circuit between the person you are testing and a tank of air with a known volume. So in this little cartoony representation, you can see the person is able to breathe from a tank which has a known volume, and we will call that V1. V1 is the known volume of the tank that you are going to let this individual breathe from. We know the concentration of a specific gas, and in this technique we use helium. We know the concentration of helium within this tank. So at the start of the test, we know the volume of the tank and the concentration of helium. Now, we use helium in the helium dilution technique because it has a very low solubility and very little will be absorbed into the body. So this individual could breathe helium in and it won't get absorbed into the blood and lost through the circulatory system. The helium that enters the lung will stay there. It won't, very, very little will be absorbed. So if you think of this picture as this tank of gas here, what we're trying to measure is the volume of this tank here when that volume starts at FRC. If we exhale down to FRC, could we somehow use the distribution of helium into kind of a second tank, the lungs being our second tank, and calculate out what the FRC would be? In other words, if we know concentration 1 and we know volume 1, if we opened these two sections up together and let the person breathe, kind of connected the red lines, made this all one tank, that would be a new volume, and we'd have a new concentration because the helium would disperse among the lung and wouldn't get absorbed in the blood. Kind of looking like this. So if picture number 1 is the start of the test, you have the person breathing room air. There is this, I don't know if you can see it very clearly, there's like a spigot here blocking the tank. And you say exhale naturally to the end of your resting breath. And then you pulled that spigot up. So at the moment when they start breathing the helium in, the volume in their lung is the functional residual capacity, right? Because at the end of a resting breath, they have exhaled to FRC. At that moment, you open the stopcock, and now they can breathe freely only from the tank. This is a closed circuit. This is the only thing that's moving in and out of the lungs. So that now you have a new volume. And V2 is your original volume plus FRC. Because we've created just one big tank. So V2 is the original volume plus that empty lung volume that we started with, FRC. So let's write this out again. C1 times V1 equals concentration 2 times volume 2. So we know the concentration that was in the tank to start, and we know the volume that was in the tank to start. The device can measure the new concentration. That's a measurable value. And we could actually change V2, right? We could say this is actually V1 plus FRC. So if we rearrange this, right, it would be C1 times V1. We could actually divide out that C2. Let's take C2 out of there. Now suddenly we have this equal to V1 plus FRC. You can simply subtract off that known original volume, C1 times V1 over C2 minus the original volume will give you the volume of FRC. So this technique works because we are measuring the concentration of helium. And helium doesn't get absorbed into the blood. So when you open that stopcock up and let the individual breathe just from this tank, we're not removing the gas, we're just diluting the concentration because we've allowed it to go into a larger volume. Since the total amount of helium doesn't change, we can make C1 times V1 equal to C2 times V2 and exploit our known volumes times the measurable concentrations to get at this kind of mystery lung volume that's very difficult to measure directly because of residual volume. So spirometry can measure volumes directly. Basically, if we can move them in and out, we can measure them directly. We can utilize the helium dilution method to get volume measurements of some of our lung volumes we don't have access to, like functional residual capacity. And finally, we can measure diffusion capacity using carbon monoxide. We use carbon monoxide because it has an extremely high affinity for hemoglobin. This is the reason why people get carbon monoxide poisoning, because if hemoglobin is given the choice between carbon monoxide and oxygen, it would much rather go with carbon monoxide. So when you have a mixture in like your house, let's say you have a carbon monoxide leak and you have a mixture of oxygen and carbon monoxide you're breathing in, your hemoglobin gets completely saturated with carbon monoxide and there's less binding availability for oxygen, and that's how you get carbon monoxide poisoning. So because it has this really high affinity for hemoglobin, basically, if the carbon monoxide gets in there, it's going to diffuse across because it wants, again, that hemoglobin so bad. So you can exploit this and actually measure the diffusion capacity by having the patient breathe out and then take a big as breath in as possible from a tank that has carbon monoxide. Hold your breath for a split second and then exhale all the air out so that almost no air is left in your lungs. And you can measure the volume of carbon monoxide that went in, and you can measure the volume of carbon monoxide that came out, and whatever doesn't come out, diffused, right? So the difference between the carbon monoxide in and the carbon monoxide out shows you your diffusion capacity. If diffusion is normal, that carbon monoxide should cross the alveolar membrane, get into the blood, and when you go to exhale, it won't be there anymore, right? It'll have diffused and it'll have dissipated into the body. If you have a poor diffusion capacity that doesn't allow adequate rates of diffusion, you will breathe out a lot more of the carbon monoxide, less will have had a chance to diffuse. So you can use this to get measurements of diffusion. Now, I feel like every year when I talk about this test, someone asks me like why this doesn't poison the person, especially because I almost always use the explanation ahead of time of carbon monoxide poisoning. This is a single breath. So if you have carbon monoxide in your house, you take breath after breath after breath after breath, and you slowly, fully saturate your hemoglobin with carbon monoxide. This is a single big breath in. It is okay. The amount of hemoglobin that continues to circle through your blood, there's tons and tons and tons of hemoglobin. So the amount that happened to get caught in that one breath does not have any long-term negative consequences. So the results of these tests can help to diagnose multiple lung disease, and this slide is showing you things that help to diagnose restrictive lung disease. So in general, we expect a reduction in total lung capacity in a restrictive lung disease because it is difficult to get air in. That means that we will have kind of less vital capacity to play with because we can get less air in. When we look at up here on the left, when we look at flow rates in relation to volume, the magenta, purple, I'm not sure what this, reddish pink, the inside circle, I can't tell what this color looks like on your screen. The inside circle represents a flow volume loop of a patient with pulmonary fibrosis. You can see the volume is much smaller. The flow rates are reduced simply because if you get less in, you have less to push out. If the reason your maximal flow rates are as high as they are is because you have maximal elastic recoil because you filled your lung so big, if an individual can't fill their lung as big, they have a less contribution of elastic recoil simply because they're at a lower lung volume, and that results in a lower maximal flow rate. So classic finding here is a reduced forced vital capacity and a reduced forced expiratory volume in 1 second. And again, I feel like the board exams just love this one because if you're going to guess, you're probably never going to guess that something's normal in a lung disease. So star it, nurture that seed that got planted in PathoPhys. Restrictive lung dysfunction classically has a normal FEV1 to FVC ratio because they're both reduced. So when you are taking your board exams, hear my voice. Don't be afraid of selecting normal. This one's normal because it's a ratio of 2 abnormal values. All right, and they also have reduced diffusion. So these are just a few additional resources. If you'd like more information about these tests, you can certainly look further into it. So if we go back to our patient that was admitted and now look at the pulmonary function test results from this chart review that we're doing from a million years ago, you can see FEV1 is reduced. Well, I need a different color here. FEV1 is reduced. FVC is reduced. So when you make these ratio, it's quite normal. Diffusion capacity is 47% of predicted. Yikes, that is not good. So this patient was treated with an immunosuppressor and put on 4 liters of supplemental oxygen, transferred to the floor, and there are orders for PT to come in and evaluate and treat. So in your notes, you can see these charts of ABGs and the complete blood count. And in the second from the left column is the values at admission. And now the last column is showing you the most recent value. So if we start on ABGs, the supplemental oxygen has improved his arterial oxygen. Carbon dioxide has gone up. So it is likely that the oxygen support has slowed down his breathing, so he's not exhaling off all that CO2. Bicarb is in the normal range. Oops, this is a typo. Is that in your notes too? This is supposed to be 7.42. 1.42 his pH. That's not even a thing. Okay, so obviously the oxygen has helped somewhat, although this is still problematic, right? 85 is still really low. Hemoglobin and hematocrit have not significantly changed because this is likely a result of the chronic low oxygen. Okay, so your body, your red blood cells live for 3 months. So you're not going to suddenly make a change in hemoglobin and hematocrit by adding oxygen, and your other values have not changed. All right, so let's do our assessment. We inspect the patient. He is alert and oriented. He has good color and normal weight. He's resting comfortably with no visible signs of distress. We do observe hypertrophy of the accessory muscles of respiration with prominent clavicles. That is an expected abnormal finding with a patient who has a diagnosis of pulmonary fibrosis. And he has symmetry of chest. That's also very fitting. This typically does not just affect a single lobe. It would be kind of a global situation. He still is exhibiting a tachypnic breathing pattern. So normal respiratory rate is 12 to 20 breaths per minute. His respiratory rate is 28. And tachypnea tells you one more piece of information, or you're describing, I should say, in your note, one more piece of information here. It's a fast rate with a shallow depth. Otherwise, it would be a hyperventilation, would be the description. His inspiratory to expiratory ratio is normal. He rates his dyspnea a 2 on a 1 to 10 scale, which means he is aware of his breathing. 2 would be kind of slight dyspnea. Normal extremities. He has no signs of digital clubbing or cyanosis. So this would tell me that the chronic work of breathing that I see with the accessory muscle hypertrophy has not resulted in chronic tissue hypoxia, or at least he didn't respond with clubbing to chronic tissue hypoxia. And no cyanosis is missing a sign of an acute lack of oxygen. When you do your lung auscultation, there are reduced breath sounds. This is an expected abnormal finding with pulmonary fibrosis because of the low volumes. If someone is taking shallow breaths, it can be very hard to hear, and diminished breath sounds is a common finding. You also hear late inspiratory crackles in bilateral bases that did not clear with cough. If they cleared with cough, the crackles were likely secretions and fluid in the lung. Because if you cough, you can move those secretions into neighboring airways, and you might not hear just the same, or they can clear it completely and they no longer have the crackle. But crackles can also be collapsed airways that are snapping open on inhalation. So with stiff alveoli, they are not fluid filled, but rather collapsing because of the low lung volumes. And when you're asking the patient to take a deep breath in, they're snapping open their alveoli. You palpate a normal tracheal position, although they do have reduced chest expansion, and you would like to assess their activity. In the pulmonary the assessment lecture, I talked about how important it is, the fifth vital sign. How do they respond to activity? But it is important to make this choice through clinical decision making and ensure that it is safe to proceed and to make these assessments. There will definitely be cases where it is just not safe to assess activity. So these parameters are in your notes for you, but these are parameters indicating lack of readiness for physical therapy. So if the pulmonary oxygen levels, if the saturation levels are too low, or if when you start to move them, they go 10% below resting levels, that might be a reason to stop. Very, very high respiratory rates. We are going to talk about PEEP and FiO2 in our oxygen lectures. But basically, this is showing you how much more support they're getting above atmosphere. PEEP is positive end expiratory pressure. That's added pressure above atmosphere that can be added to help drive air into your lungs. If you're requiring very high amounts of extra pressure to drive air into your lungs, you are on a high degree of support from mechanical ventilation. And FiO2 is the fraction of inspired air. that goes up when you're on oxygen support. So this value, FiO2 greater than 0.6, is basically saying an FiO2 of 60%, which is equivalent to about 10 liters per minute of oxygen flow. So if you've been a little more familiar with liters per minute flow rates, that's how that normally kind of associates. We will have an oxygen lecture where you feel more comfortable with those numbers and how to kind of move between them. Cardiovascular measures, if heart rate is too low or too high, if systolic blood pressure is too low or too high, if arrhythmias are developing, if they have angina, and then there's certain characteristics for dialysis patients, and then blood glucose levels as well. And this is a decision-making algorithm tree to help you make this decision. Basically, if these critical values that were on the previous slide are not present, so they're not on undue supportive oxygen, their cardiovascular parameters are within a stable range, the patient is ready and you want to proceed with the following questions, and that is their cognition status. So critical values being stable is number one. Being able to follow some kind of a command can be the difference between whether or not it is safe. And if they can't follow such basic commands as open and close your eyes, you might choose to say, this patient is not ready for physical activity, and wait. If they can answer, if they can follow simple commands, and their critical values are stable, you can proceed with the assessment. So we will evaluate this patient's response to activity. Some of you probably do this already, but I want to do the quiet part out loud in class and actually say what we expect to happen. Before every single patient, before you get them out of bed, you should have already kind of decided what you expect to happen to their vitals, because it will help you react quicker and more appropriately when you see it happen in real time. So what do we expect to happen to this patient's respiratory rate? Well, he's already tachypnic. This is already a high respiratory rate. What normally happens with activity? I'd normally expect respiratory rate to go up. So this might go up a little further. If there's no change in respiratory rate above resting, this might suggest to me that he's already kind of in his respiratory reserve. He might not have kind of any more breath to get, and then activity could become quite dangerous, right? Because we need to be able to tap into our reserve volumes to get more oxygen above rest. Right now, this rate is feeding his resting demands, albeit maybe not great. So I expect this to go up a little bit. If it doesn't go up at all, I am going to be checking some of these other parameters to see if I need to terminate exercise. All right, oxygen sats, 95%. I'm feeling good about that. So good at rest. What do I expect to happen? In a normal, healthy person, oxygen saturation should not change with exercise, right? All of you, even when you're maximally exercising, you should still be saturating your hemoglobin. This patient has pulmonary fibrosis with 47% predicted diffusion capacity. I am very concerned about whether or not this number will hold. This is probably going to be one of my priority vitals to be tracking with a patient with such a severe diffusion limitation. If I had to just guess, right, based on my findings thus far, I have a feeling that it's going to be his oxygen levels that will be our limiting factor. All right, heart rate is 62, normal. This patient doesn't have any known or reported cardiac issues. So what do I expect to happen? I expect a normal linear increase in heart rate to activity. If I don't see that, that would be surprising. Or if it jumps really high, it could be a sign that he's in distress, probably over here in one of these values. It should be a nice gradual increase. BP 142/78. So he's a little hypertensious. Hypertensious? That sounds funny. Has a little bit of hypertension. You guys, I'm cracking myself up all alone in my office. Oh, I miss real students. Okay. He's a little hypertensive. How about that one? But he has no cardiac issues. So he's probably under some stress here, right? He's in this hospital. He's having some breathing issues. It's not surprising, but I'm going to keep an eye on that. If anything, if I had to predict, I would guess he might go a little orthostatic upon standing, just because he hasn't been moving and because the fluid changes that happen when you've been in bed for a while. So I'll keep an eye on this. If I had to guess, I would guess it's going to go down a little bit, but hold, because I think he's got enough fluid to be sustained. All right, let's see what happens. All right, so supine at rest, these are the values we already have. We transfer him to sit with a min assist. His respiratory rate does go up a little bit, so this is good. He's got a little reserve. His BP does fall. Heart rate jumps a bit, but again, when you go orthostatic, heart rate can try to overcompensate for cardiac output with the loss of volume, right? Because if you don't have the volume, because you just got him sitting, fluid falls to his feet. He doesn't have enough volume to vasoconstrict it back up. He has less venous return, limiting stroke volume, so he's making up cardiac output with heart rate. So a bigger jump than I would expect if everything else was normal, but makes sense in relation to the blood pressure. And SATs fell a little, but we're still clearly in the safe range. Do I jump up to stand at this point? I think I would give this patient a minute. I'd have them sit. Maybe we would really work on sitting up straight. We could do a little scapular, pullbacks, get as best posture as possible, and kind of reassess after a minute of sitting. So after about a minute, his respiratory rate kind of goes back to resting. Blood pressure stabilizes, heart rate stabilizes, SATs look pretty good. I'm going to get this guy standing up. Let's see what happens next. We go sit to stand with contact guard assist, and he does have a respiratory rate to increase. BP falls again, kind of heart rate's trying to make up the difference, and now we've kind of dropped into the danger zone of our oxygen sat levels. So this low, you could give it a little bit, see if it bumps back up, but you're starting to get to the place here now where you're thinking, I better stop this assessment and just report my findings as part of my evaluation, how he responded to this activity challenge. But why did things get so bad so fast? Especially compared to, he was doing really good at rest. What is the difference between these two? He's just standing up. Why did it fall so far? Well, remember, we get oxygen in our blood as it diffuses across the alveolar membrane into the blood as it goes through the lung. So a physical red blood cell has to enter the capillary, flow through that capillary, and then leave the lung. And this all takes time. This is a graph straight from your pathophys notes that has time on the x-axis and PO2 on the y. Starting at 0 time point, you have the pressure of oxygen of venous blood basically entering the blood here. And in resting state, you typically have about 0.75 seconds of time for that red blood cell to be floating by the alveoli to take on oxygen. So in a normal individual, we fully oxygenate our hemoglobin in about 0.2 seconds. So here, black line is normal. So look at this. We're like full here. So basically like this blood cell here has all of the oxygen it will ever get. And then it just floats along, picking up no more oxygen. It just floats along and goes for a ride, fully oxygenated. We have a ton of buffer room. At rest, if you have a diffusion limitation, even if you are 75% reduced, and the time for diffusion, if the rate of diffusion is so low, you need extra time for diffusion, you have it built into the system. because the amount of time that it floats by, you have all this extra time that at low diffusion rates, you can still fully oxygenate the hemoglobin by the end. So he was sitting in bed at rest. His red blood cells had 0.75 seconds to be exposed to the alveoli to pick up their oxygen, and he was satting just fine. Then you, Super PT, showed up, had him transfer supine to sit, and then sit to stand. You induced an exercise challenge, and you increased his heart rate, and you increased his cardiac output, which means during exercise, blood is flowing through the pulmonary system faster because your heart is beating harder and faster. Suddenly that 0.75 seconds turns into 0.25 seconds that a red blood cell has exposed to an alveoli to pick up its oxygen. You removed the buffer of resting blood flow to make up for that diffusion barrier. And now suddenly they're barely getting their hemoglobin saturated, and the red blood cell is left the lung without oxygen attached, or inadequate amounts of oxygen attached. So it's not just that exercise increases oxygen consumption, which it does. It also, because we increase the flow of blood through the lungs, it decreases the time for diffusion to occur. So what do we find? We have a 55-year-old male presenting with decreased physical activity and exercise tolerance due to dyspnea in the presence of signs and symptoms consistent with an acute exacerbation of pulmonary fibrosis. In this class, we will go through the different interventions. So for right now, so you have it in your notes, when this class is complete and you might be going back and reviewing anything and you can see where these interventions fit in. But a patient like this, we would take time for education. We'd use aerobic exercise, strengthening exercise. We work on chest wall mobility, possibly body positioning, effective coughing, relaxation techniques to kind of try to counter that tachypnic breathing pattern, and then talk about pacing and energy conservation. So I'm going to end this video here. We will start with the next case in the next restrictive lung disease video. Thanks for your attention.